Hello again everyone, and welcome back to the channel. In part 2 of this talk, we'll be looking at interpretation of arterial blood gases and solve a few clinical scenarios together. Before moving on to the scenarios, let's have a look at some of the important parts of an ABG. So we have the fraction of inspired oxygen, which is from 21% onwards. It's the amount of oxygen you give your patient temperature, the basic acid-base abnormalities over here, from the pH to the base excess. We have a look at the electrolytes such as potassium and sodium, metabolites such as glucose and lactate, the normal value of lactate being less than 2, and oxygen status. Now we have more parameters over here, however I've only added the hemoglobin and saturation levels for simplicity, and this will also help you answering exam questions, although it's not necessary to know every component of this. We'll also have a look at the PO2 levels and how to estimate them based on our FiO2 levels. Basically what you do is you just subtract 10 from the fraction of inspired oxygen, and that should give you roughly how much the PO2 is meant to be. So for instance, if you have a healthy person who's being given about, say, 50% FiO2, minus 10 would be 40 kilopascals of PO2, this parameter right here. Okay, so that's one useful tip to know. Another one is the saturations of oxygen. So if you've taken an arterial sample, the saturations on the ABG paper are going to be in the 90s, but if it's a venous sample and you thought you've taken an arterial sample, it's going to be around 70s. So that's how you can differentiate. Another way is also looking at the blood in the syringe. Bright red would be arterial and dark blood would be consistent with the venous gas. So if there is any doubt, unfortunately, you'll just go back to the patient and repeat the arterial stab. A quick revision, I'm sure you know a pH of less than 7.35 would be consistent with acidemia, greater than 7.45 would be alkalemia, and the respective processes driving these are referred to as acidosis and alkalosis. An oxygen saturation of less than 10 would indicate hypoxia, less than 8 would indicate either type 1 or type 2 respiratory failure. Value of bicarbonate less than 22 would indicate a metabolic component to the acidosis, and greater than 28 would mean a likely metabolic alkalosis. Bear in mind that the most important components of the acid-base abnormalities are the bicarbonate and the PCO2, because it's these two which directly influence the pH you have. We'll have a quick look at the base excess on the next slide. It is also very important to bear in mind that in terms of the compensation aspect, the lungs are going to compensate for the abnormality within minutes, whereas the kidneys will take hours to days. And you'll see why this is important. So what is the base excess? So it's the amount of strong acid that must be added to a liter of oxygenated blood so that the pH goes back to 7.4 at 37 degrees Celsius and the PCO2 being 5.3 kilopascals. And on the other hand, base deficit, meaning too little base, or also known as a negative base excess, would be defined in terms of the amount of the strong base that needs to be added. So the values of base excess are from -2, let's just assume 0 is here, and +2. So this is nothing to be confused about. You know, you can have values of +3, +4, and so on. And on this side, you'll have -3, -4, -5, and so on. What this indicates is, in this direction, it will be an alkalosis, and in the negative direction, it will be an acidosis. So basically, if the pH is abnormal, and if you see an abnormality in the base excess, all it does is it just confirms your findings. It doesn't give you any more information, or it definitely doesn't change your answer in the exam either. That's all it does, is to show in which direction the acid-base abnormality is, okay? So I wouldn't worry too much about this definition, but I thought it'd be important for your own knowledge and interest. So I hope you're all ready. Let's move on to solving the first question. So feel free to pause the video. We have a 65-year-old lady who's 3 days post laparotomy, and her ABGs are shown on room air. Let's have a look at the abnormalities. So she's slightly alkalemic here. PO2, she is hypoxic. PCO2 is less, meaning she's hyperventilating, and the bicarbonate is normal, so is the base excess. So this is a respiratory alkalosis, and she is in type 1 respiratory failure, and that's because the PCO2 is less than normal, but she's also hypoxic at less than 8 kilopascals. Also have a quick think about why this is happening. She's 3 days post-op and she's had a laparotomy, which is big stress to the body. She may be in pain, not breathing very well, hence the hypoxia. It could also be basal atelectasis, as can happen 48 to 72 hours post-op. It could be a hospital-acquired pneumonia. It could also be a pneumothorax. I know it's also important to think about a pulmonary embolus in a post-operative patient, although these happen usually around the 1 week mark. Moving on to the next question. You can pause the video now. So we have a 69-year-old lady who's short of breath and drowsy, and she's on 36% FiO2, which means that her PO2 ought to be around 26, but it's way below at 7. So let's have a look at the pH then. She's acidemic. She is quite hypoxic, so she's already in respiratory failure. Her PCO2 is also raised, so we know that this is a type 2 respiratory failure. And the bicarbonate levels are normal, and so is the base excess value. So this is a primary respiratory acidosis. I hope that makes sense. And she's also in type 2 respiratory failure. Let's move on to the next question now. So this is interesting. We've got a 26-year-old doctor coming in because she's short of breath, and it turns out she's got a PLAB exam coming up next week. She's usually fit and well, and her blood gas on room air shows a pH of 7.47, so we know she's alkalemic. PO2 is normal, PCO2 is reduced, 3.5, and her bicarbonate and base excess levels are normal, so this is a respiratory alkalosis. So this one is relatively straightforward and easy, and this is happening because of her anxiety due to the upcoming exam. So question 4, we have a 31-year-old male who's got abdominal pain. He is dehydrated and confused. His arterial blood gases on room air show a pH of 7.23, which is quite reduced. PO2 is normal, PCO2 is reduced at 3.8, bicarbonate levels are quite reduced at 14, and this is also confirmed by the negative base excess going in the acidemic direction of -6, and the glucose of 24 might give you a hint towards the diagnosis. So this is a metabolic acidosis. And notice how the PCO2 is also less. We know that CO2 is an acidic gas, so the body is going to compensate by breathing rapidly. The patient is going to be tachypneic to blow off the CO2 in order to compensate. So this will be a respiratory compensation. But because the pH is still abnormal, this is a partial respiratory compensation. So the overall picture is of a metabolic acidosis with partial respiratory compensation, and the underlying diagnosis is diabetic ketoacidosis. I hope that makes sense. Let's have a look at question 5. We have a 91-year-old male who's got a fever, so this should immediately lead you to think that this is likely to be sepsis. He's hypertensive and confused. ABG on room air shows pH of 7.2, again acidemic, PO2 of 9.8, just about hypoxic, but not enough to cause respiratory failure, because remember, that's going to be less than 8 kilopascals. PCO2 is raised, so they're retaining CO2. Bicarbonate levels are again quite low, and the base excess is also -4, thereby confirming the directional change towards acidemia. So this is a picture of a mixed metabolic and respiratory acidosis, because see how the bicarbonate levels are low and also the CO2 levels are increased, meaning this acidic CO2 is being retained in the lungs. I hope that also makes sense. Let's move on to the next question. So in this case, we have a 70-year-old gentleman with COPD who presents with a cough and fever. This is likely to be an infective exacerbation of COPD or even a community-acquired pneumonia. His blood gases are shown on 21% oxygen, i.e. room air, so the pH is reduced at 7.31. PO2 is also low at 7.2. And the PCO2 is raised, so this is type 2 respiratory failure. And the bicarbonate levels are slightly above normal at 30, and this also confirmed by the base excess of +3. So the overall clinical picture here is acute on chronic respiratory acidosis. Let me explain the chronic aspect of it. So COPD patients are chronic CO2 retainers, so even if they're not in hospital and at home, the PCO2 levels are going to be raised above 6.1, okay, if you do an arterial blood gas on them. That's because the pathophysiology of COPD is such that you end up retaining carbon dioxide, which is an acidic gas. So in order to compensate for that, the kidneys are going to end up retaining a lot of bicarbonate, okay? And this is a process which may, happen over days, months, years. We know that, it starts within hours in the kidneys, the process of compensation. So this compensatory mechanism may well have been enough to maintain the pH between 7.35 to 7.45. But the underlying fever, cough, likely infective exacerbation, or even a pneumonia has overwhelmed the physiology, and therefore this bicarbonate level is still not sufficient to counteract the reducing pH and the acidemia which ensues. So a slight rise in the PCO2 level is going to slip the patient into acidosis, and hence this is an acute on chronic respiratory acidosis. I hope that makes sense. And having a look at the last case, we have a 58-year-old lady with a gastric carcinoma causing gastric outlet obstruction and profuse vomiting. Her arterial blood gases on room air show a pH of 7.53, which is raised, so this is an alkalemia. PO2 is normal, PCO2 is also normal, but bicarbonate is raised at 33, showing a metabolic process, and this is also confirmed by the base excess, which is 3 more than the upper limit of the normal value, which is +2. So this is a metabolic alkalosis. There is no compensation at the moment, but the compensation would be hypoventilation, reducing the respiratory rate so as to retain CO2, which again is an acidic gas, in an effort to reduce the pH and drive it towards the acidic side. But that hasn't happened in this scenario. And the reason this is metabolic alkalosis is because you vomit out the hydrochloric acid produced by the stomach, so you have less amounts of hydrogen ions to buffer the bicarbonate, which is more freely available now. Dehydration secondary to vomiting will trigger the renin-angiotensin-aldosterone system. Aldosterone is going to cause absorption of sodium ions at the expense of losing hydrogen ions in your urine and making it more acidic. So I hope that makes sense. If you have any questions or comments, please leave them below and I'll do my best to get back to you. It'll be a big help if you could like or subscribe to the channel, and I'll do my best to make sure I'll produce quality content sometime in the near future. Thank you.